Good afternoon, I'm Lieutenant Stanwyck here with Lieutenant Daly and Lieutenant Richter. Today we're going to give you an evidence-based review of functional outcomes for the treatment of acute inversion ankle sprains. Okay, so the topics covered are an overview of ankle inversion sprain, surgical versus non-operative treatment, benefit of adding exercise and manual therapy, the use of ultrasound and taping and bracing. Our search strategy includes these keywords as well as the databases are below that we utilized.
Yeah, etiology and mechanism here. If we talk about inversion ankle sprains, they account for about 75% of all ankle sprains, with 25% of all musculoskeletal injuries being inversion ankle sprains. 50% of these inversion ankle sprains are sustained while playing sports. You're much more likely to sustain an inversion ankle sprain or an ankle sprain in general if you're active, so they are very much the STDs of injuries. The anterior talofibular ligament, the ATFL, is most commonly damaged ligament in inversion ankle sprains, accounting for about 66% of the cases. Plantar flex in supinated ankle position puts the ATFL in a taut position where it's more likely to be damaged. The ATFL and CFL occasionally are damaged in about 20% of cases, so that CFL is added in. And the PTFL, the posterior talofibular ligament, is very rarely injured based on its position and its strength. The clinical signs and symptoms, we're going to go over a three-tiered grading system for assessing ankle sprains here. Grade 1 corresponds to a partial tear, where the participant is able to continue with activity and there's slight or no pain exhibited. You might have mild tenderness and swelling, if you have any at all. Really no ecchymosis witnessed at all. No mechanical instability if this person even chooses to come into your clinic as a PT. And the recovery timeline is very brief. I mean, over the course of about 7 days, you should be recovered. Grade 2 is an incomplete tear. There is pain with weight bearing and ambulation. They may have had to sit out the remainder of the game, or they may have continued to play on it and go sort of work through the pain. There is moderate swelling and tenderness to palpation, with maybe some mild to moderate ecchymosis visible. There's mild to moderate mechanical instability, and recovery timeline ranges between 10 and 30 days, with the average being around the 3-week mark. Grade 3 is a complete tear of the ligamentous structures. The person is unable to bear weight or ambulate. There is diffuse edema and tenderness to palpation both medially and laterally due to that diffuse edema, and there will definitely be ecchymosis, and most likely it will be severe on the lateral aspect of the ankle. Moderate and severe mechanical instability is exhibited as a result or through a clinical exam, and the recovery timeline ranges from about 30 to 90 days, with an average of about 40 days for recovery. So looking now at diagnosis. For acute ankle inversion sprains, initial assessment within 48 hours is definitely necessary to rule out the possibility of fracture, and that's when you're going to be using those Ottawa ankle rules to great effect. But in determining the grade of ankle sprain and maybe which ligamentous structures are damaged, it is not particularly accurate. So the most accepted approach is to conduct a delayed examination about 4 to 5 days post-injury, when the patient has had a chance to calm down and your palpation skills will be a little bit more accurate. And you'll also be able to conduct that anterior drawer test of the talocrural joint and actually get some findings. And instead of deferring due to pain. The most relevant objective exam findings you're going to consider here are swelling and edema, ecchymosis, localized tenderness to palpation, and a positive anterior drawer. So if you just look at the anterior drawer alone, you get a sensitivity that's not very good, maybe 73%, and a specificity of about 97%. However, if you add tenderness to palpation over the ATFL and exhibition of ecchymosis to a positive anterior drawer test, your sensitivity jumps up to 98%, you get a specificity of 84%, and overall it's a very good and effective means of assessment.
Okay, so treatment options for these ankle sprains first immediately is going to be RICE, rest, ice, compression, elevation. Then there's 3 main categories you can follow afterwards: immobilization, functional treatment, or surgery. The functional treatment consists of Therex, manual therapy, or protective devices. However, the treatment overall is going to depend on the severity of the sprain. Grade 1 and 2 are usually managed with immobilization or functional treatment, while patients with grade 3 sprains are more likely to be candidates for surgery. Surgery involves ligamentous repair of torn structures such as the ATFL, CFL, or PTFL, or reconstruction depending on the extent of the damage. So next we're going to look at a Cochrane review that compares surgery compared to conservative treatment. 20 trials were reviewed over the past 30 or 40 years with a total of about 2,500 subjects with acute lateral ankle sprains with confirmed ligament rupture. So these were grade 3 sprains. The primary outcomes were return to pre-injury activity, occurrence of re-injury, pain, and subjective instability. Results: non-operative treatment resulted in a shorter time to resumption of pre-injury activity. However, surgery resulted in a decrease in recurrent ankle sprains. Surgical treatment demonstrated less frequent subjective and functional instability. However, this was not statistically significant. So overall, there's insufficient evidence for the effectiveness of surgery versus conservative treatment in acute lateral ankle sprain injuries.
Now moving on to exercise-based interventions, we're going to look at a study called the Effect of Accelerated Rehabilitation on Function After Ankle Sprain. This was a randomized controlled trial conducted in the UK. There were 101 participants total, age range between 60 and 65, who had suffered a grade 1 or 2 acute inversion sprain of the ankle within 7 days. So the primary outcome measure looked at here was a lower extremity functional score, and a secondary outcome measure was the amount of physical activity as assessed by a pedometer that the study authors had used. The methods here involved treatment. So the treatment provided during that first week differed between the two groups. Both groups received icing and compression, and the exercise group furthermore received a standardized Therex routine, which amounted to basically a home exercise plan with DVD instruction. Now, after that 1 week mark, standardized treatment was applied to both groups, where both groups received Therex, focusing on muscle strengthening, neuromuscular training, and sport-specific functional exercises, with one in-clinic treatment session per week and 4 additional home exercise treatment sessions for a total of 5 per week. The results showed that the exercise group's mean lower extremity functional score scale scores were significantly higher than the standard treatment group for weeks 1 through 2, and after 1 week the exercise group was significantly more active. So we concluded, at least from this article, that significant short-term improvements in ankle function may be possible when compared to the standardized conservative treatment if therapeutic exercise is incorporated within the first week for grade 1 and 2 ankle sprains.
Our next study is a systematic review published in the JOSPT, comparison of conventional and supervised rehabilitation for treatment of acute lateral ankle sprains. That ended up getting 7 RCTs, looked at 5 different databases. Some of the requirements said the subjects had to have acute lateral ankle sprains. At least one of the treatment options had to be conventional treatment, as cold packs, complete or partial mobilization with casts, brace, bandage, weight bearing is tolerated, on crutches, instruction on early ankle exercise or home exercise program. And the third requirement was at least one treatment option consisted of conventional treatment with supervised rehabilitation training. That's your typical physical therapy in-clinic visits, with emphasis on like balance training, wobble board, and coordination exercises. Functional outcome measures were time to return to sports and time to return to work. There's a host of other secondary outcome measures. The study quality was determined by a Delphi list. It was a set of 9 criteria. They also added 2 more from the Cochrane musculoskeletal injuries group, totaling 11 questions, 1 point each, very similar to the Pedro score, which you're familiar with. The RCTs were too diverse to analyze quantitatively, so they didn't look at it qualitatively. They pulled a rating system from a reference article from a Cochrane systematic review, just 1 to 5, 1 being strong evidence, 5 being no evidence. And what they did find was a 3, which is limited evidence for overall outcomes, and then they found no statistically significant differences when looking just at functional outcomes.
So now I'm just going to piggyback on what Lieutenant Richter just talked about. This was a systematic review conducted in 2010 of a lot of different articles. However, the 3 studies that they looked at that looked specifically at functional outcome measures were the ones that I chose to focus on here. The subjects included for the systematic review were adolescents or adults with acute lateral ankle sprains. The outcome measures considered here were lower limb task questionnaires, motor activity scale, the Carlson scale, and foot and ankle outcome score. The methods here, so there was really no standardized conventional treatment. It could amount to basically no treatment, the use of ice, partial or complete immobilization, a home exercise plan, instructions for ankle mobilization, or a combination of any number of these. And there was also similarly a very large variation in the number of visits and the duration of treatment for the treatment groups receiving exercise. So the fit parameters were not very well specified. So the results here, there are no significant differences in functional scale scores for the supervised exercise groups versus the conventional treatment groups at either short-term follow-up or long-term follow-up. So a little bit different than the other study that I presented on. But the conclusions here are that the addition of a supervised exercise plan to conventional treatment really does not improve short or long-term functional ability.
Alright, so next we're going to explore the effects of manual therapy on acute inversion ankle sprains. This was a single-blind randomized controlled trial with 17 subjects with grade 1 or 2 acute lateral ankle sprains. They were immobilized post-injury for 1 to 7 days with a walking boot. They were randomized into two different groups, a treatment group and a control group. The treatment group received one bout of anterior-posterior talocrural joint mobilization for 30 seconds on the day that their cast was removed, and the control group received no treatment after the walking boot was removed. So outcomes included dorsiflexion range of motion, posterior talar transition, and self-reported function through the use of a foot and disability index questionnaire, and this was measured both before and 24 hours post-treatment. The results, both groups improved in dorsiflexion and self-reported function. However, neither group reached the MCID of 9% on the Foot and Disability Index questionnaire. So the next was a randomized control trial of a passive accessory joint mobilization on acute ankle inversion sprains. This involved 41 subjects with sprains in the past 72 hours. They also demonstrated tenderness to palpation along the lateral collateral ligaments. There's two groups, or intervention groups, a control group and a treatment group. Control group was prescribed rice, and the treatment group was prescribed manual therapy in clinic in addition to rice. Manual therapy included 2 repetitions of 60-second anterior-posterior talocrural joint mobilizations with 10-second rest in between. And this was conducted every other day except for on weekends for 2 weeks. Outcomes included dorsiflexion range of motion, stride speed, step length, and single support time measured both before and after each treatment session. Results included greater dorsiflexion and stride speed in the treatment group. There is no difference between groups in step length or single support time.
So these are just a few other treatment methods we found searching through the literature. The first one's on therapeutic ultrasound for acute ankle sprains. So 500 review. Ended up looking at 5 randomized control trials of ultrasound versus the ultrasound sham treatment. That's just turned down to 0 watts per centimeter squared. Then looked at functional outcomes they looked at were general improvement and subjective functional disability. They ended up finding there was no statistical significant or clinically significant difference, 0 to 6% differences in the outcome measures. So, and then for taping versus bracing, the first one was a randomized control trial that just looked at skin complications, satisfaction, comfort, ankle joint function and range of motion. They did find a statistically significant difference and reported patient comfort, satisfaction, and decreased skin complications for the semi-rigid brace, as you see to the bottom right. The next one is a systematic review. They found 8 RCTs that treated acute ankle sprains that were treated with either ankle brace or functional treatment. Functional treatment is the 2B grip or elastic wrap, ankle tape, however you want to refer to it. And they did find the ankle brace to have greater functional outcomes. Included studies for the foot and ankle, included outcomes where the foot and ankle outcomes were return to daily activity and days of sick leave taken.
So in summary, surgery provides a better long-term outcome in terms of functional stability for grade 3 inversion sprains. However, non-operative procedures result in a faster return to pre-injury levels of activity. Immediate Therex can have a short-term positive effect on functional outcomes for grade 1 and 2 inversion ankle sprains. No statistical difference between conventional treatment and supervised exercise for grade 1 and 2. And lastly, repeated anterior-posterior talocrural mobilizations may be beneficial in increasing stride speed in patients with acute inversion ankle sprains. So here are works cited. If there are any questions, please let us know via email. Thank you.